My honor to introduce Dr. Carolyn Wester, who is the Director of the Division of Viral Hepatitis within the CDC's National Center for HIV, Hepatitis, STD, and TB Prevention. In this role, she oversees the design and implementation of national programs for viral hepatitis prevention, control, surveillance, and outbreak response. Dr. Wester received her medical degree from Dartmouth Geisel School of Medicine and a Master of Public Health from Harvard's T.H. Chan School of Public Health. Let's give her an Oregon welcome, and thank you very much.
Hello, my name is Carolyn Wester. I'm the Director of the Division of Viral Hepatitis at the Centers for Disease Control, and I want to thank you for inviting me to share CDC's plans and approaches for addressing our viral hepatitis elimination goals. Today, I will present on the most recent trends we're seeing in viral hepatitis surveillance, followed by COVID impacts and opportunities for our work. I will then provide an overview of the National Viral Hepatitis Strategic Plan and our division's program priorities for 2021. To provide context for our U.S. elimination goals and 2021 priorities, I'd like to start by looking briefly at our latest viral hepatitis trends from our 2019 surveillance report, which we anticipate being released in the next month or two. Trends in acute infections across the hepatidities are demonstrated in this slide. To orient you, the yellow lines represent reported cases to CDC, whereas the blue bars represent total estimated cases. As evident in this slide, hepatitis A incidence has increased dramatically since 2016 due to widespread person-to-person outbreaks. Hepatitis B cases have remained relatively flat, despite the fact that this too is a vaccine-preventable infection. And finally, we've witnessed more than 10 years of consecutive increases in reported cases of acute hepatitis C, paralleling similar trends seen in opioid use disorder and overdose deaths. As we turn to hepatitis-related deaths, we see here the age-adjusted hepatitis B related death rates, as shown in purple, have remained relatively flat, yet we have seen existing and persistent disparities affecting certain racial ethnic minority groups, particularly Asian and Pacific Islanders, as well as non-Hispanic Black persons. Regarding hepatitis C, we've seen related deaths in the US begin to decline since 2014, following the introduction of direct-acting antiviral medications and expanded hepatitis C testing recommendations. However, as seen with hepatitis B, significant death-related disparities exist with hepatitis C, particularly among American Indian, Alaska Natives, and non-Hispanic Black persons. While the primary focus of my talk will be on hepatitis C, there are some significant intersections between the hepatidities. So I wanted to briefly summarize some of the trends we're seeing with respect to both hepatitis A and acute hepatitis B infections. First, as I mentioned previously, the US has been experiencing unprecedented increases in hepatitis A driven by widespread outbreaks among person-to-person spread, particularly among people who use drugs and also people experiencing homelessness. As of the end of February of this year, 35 states have reported hepatitis A outbreaks, and as indicated by the map on the left, 9 states, shaded in gray, have declared an end to their outbreaks, whereas 26 states continue to have active state or local outbreak declarations, most markedly in Appalachia and the surrounding region. While we continue to see some smaller outbreaks occurring in a few new states, the overall epi curve shown on the right is encouraging. Beginning in the last 4 months of 2019, before the escalation of COVID cases, we saw about a 50% reduction compared to peak, and we've continued to see further case reductions since. Regarding acute hepatitis C, on the left, we see rates, highest rates among individuals in their 30s, 40s, and 50s. Additionally, on the same graph, we see lowest rates among our 2 youngest age groups, reflective of the effects of implementing routine childhood vaccination 29 years ago in 1991. The pie chart on the right illustrates risk factors associated with reported cases of acute hepatitis B, Of persons with reported risk, and that's only about 50% of the cases, a history of injection drug use was most commonly reported, followed by multiple sex partners. Now we'll return to acute hepatitis C, for which, as I mentioned, reported cases have increased dramatically over the last 10 years, and rates continue to rise with nearly 60,000 estimated acute hep C infections occurring in 2019. On the top left, you can see that rates have increased over time for all adults, with the most dramatic increases among adults in their 20s and 30s, or reproductive age adults. The bottom left of the slide illustrates that over the same period of time, American Indian, Alaska Native, and non-Hispanic white persons had both the highest rates as well as the highest increases. On the right, reported risk behaviors are illustrated. And as you can see, a history of injection drug use was reported most commonly in about 70% of the cases, or more than double of the next most commonly reported risk factor, multiple sex partners. This figure illustrates the number of newly reported chronic hepatitis C cases in 2019, stratified by age and sex. Given that more than half of the acute cases go on to develop chronic infection, it makes sense that we see chronic hep C infections are now heavily impacting multiple generations. Additionally, it's important to recognize that the number of reproductive age persons infected, that without access to prevention, testing, and treatment, increasing rates of perinatal transmission threaten to transform this bimodal curve into a trimodal curve. Moving to hepatitis C related deaths, these figures illustrate the rates among US residents in 2019 by sex, race, ethnicity, and age category. In the top left, we see the rates are highest among men. In the bottom left, among American Indians, Alaska Natives, and non-Hispanic Black persons. And on the right, individuals aged 55 to 74, also known as baby boomers. So to summarize, hepatitis A incidence has increased over 1,300% in the past 5 years due to widespread person-to-person outbreaks. Over half of acute hep B cases reported to CDC in 2019 were among individuals aged 30 to 49. And the hep C incidence rate, which has quadrupled since 2019, has continued to rise over the past several years, with the highest rates among individuals in their 20s and 30s. All of these trends are being fueled by injection drug use. Additionally, we see substantial disparities among racial ethnic minority groups, particularly with respect to viral hepatitis related deaths, although the groups do differ somewhat by hepatitity. As we begin to prioritize activities towards meeting our strategic plan goals, we're not only considering the impact of COVID-19, but also leveraging any opportunities presented by pandemic-related policies and practices. Like many of us, CDC's viral hepatitis program had a lot of plans for 2020. Unfortunately, COVID disrupted some of our program's work, similar to what jurisdictional partners have experienced. We saw firsthand states that were unable to keep up with their hepatitis A outbreak reporting. They also struggled to maintain hepatitis B and C testing and linkage to care and treatment services, as staff were pulled away to support state COVID-19 responses. Social distancing and other stay-at-home orders led to fewer people accessing testing and treatment services, and even the closure of providers and services, especially in non-traditional healthcare settings like syringe service programs. On the other hand, the COVID pandemic has also presented some opportunities to advance our progress towards our strategic plan goals. To accommodate social distancing guidelines, healthcare professionals have increased their use of and investment in telemedicine and safe lab testing options. CARES funding has also provided states an opportunity to invest in new, longer-term lab resources for COVID-19 testing, much of which is compatible with the platforms used to conduct hepatitis C testing. And the pandemic has also led to innovations in vaccine delivery models that can be leveraged to expand and reach settings serving disproportionately affected populations. I will now present a brief overview of the nation's 2025 strategic plan, which provides strategies and indicators towards eliminating viral hepatitis as a public health threat in the US by 2030. CDC worked closely with the Health and Human Services in support of the national plan, which was released earlier this year. The plan has 5 goals, which are listed here. The first 4 mirror exactly those released in Division of Viral Hepatitis' plan released in 2020. This table is an excerpt from the national plan and highlights some of the populations disproportionately impacted by viral hepatitis in the US. While there is certainly some heterogeneity across the hepatitis as well as stage of disease, there is also some overlap. For example, people who inject drugs have higher rates of incident infection across all 3 major hepatitis. The 2021 National Viral Hepatitis Report shown here, which includes 2019 preliminary data and will be released again in a month or 2, indicates that we are making progress in several of the nation's goals. However, increases in new infections and persistent disparities threaten promising trends towards elimination. And of course, the intersection of substance use disorder and specifically injection drug use is not unique to viral hepatitis. It is associated also with the acquisition and transmission of other bloodborne and sexually transmitted infections. So as we move to implementation, it's essential that we consider these conditions together, addressing the syndemic by engaging across national plans. I'll now discuss some of the Division of Viral Hepatitis' prioritized activities. First, I think it's important to articulate DVH's main mission, which is to provide leadership in science and public health practices to prevent and control viral hepatitis. DVH sets out to achieve this mission through the core functions which are listed here and include monitoring disease trends, detecting and responding to outbreaks, supporting health departments to conduct viral hepatitis, and also supporting health departments and working with a wide variety of partners to increase access to viral hepatitis prevention, diagnosis, and treatment services for all populations, including disproportionately impacted populations. We also seek to advance viral hepatitis research, to develop and promote national testing and vaccination recommendations, and increase public awareness. I want to briefly provide some examples of how we've put these core functions into practice. Again, while primarily focused on hepatitis C, I did want to show a few examples of activities that the Division of Viral Hepatitis conducts in support of controlling hepatitis A and B as well. For hepatitis A, DVH has provided state and local health departments with outbreak response by providing a myriad of activities, including situational awareness through surveillance, producing guidance documents, facilitating sharing of best practices, supplementing state and local resources, and also cultivating communication and coordination between both internal and external partners. Some of the communications materials developed in support of the hepatitis A outbreak response activities are illustrated here. Although those listed here focus on hepatitis A, our communications teams develops a wide array of products in support of hepatitis B and C as well. CDC is also prioritizing a number of programs dedicated to addressing hepatitis B health disparities. In May, we'll be launching the next wave of the No Hepatitis B campaign. Ads will be placed in Vietnamese, Korean, and Chinese language media with a focus on those aged 40 and older. We're also collaborating with the Office of Minority Health on a 3-year cooperative agreement supporting comprehensive hepatitis B prevention programs, including perinatal prevention through strategic partnerships. And DVH is also updating our national hepatitis B testing and vaccination recommendations for adults with an eye on moving towards universal recommendations. Moving back to C, we have focused updating our hepatitis C recommendations based on the trends that we've seen in shifting epidemiology. CDC first began publishing recommendations for hepatitis C screening in the early 90s, recommending testing of all blood and organ donations. In the late 90s, guidelines were expanded to include recommendation for testing persons at high risk, including persons who had ever injected drugs, as well as people living with HIV. In 2012, because of concern regarding limited effectiveness of risk-based hepatitis C testing, and a high prevalence of disease among persons born from 1945 to 1965, also known as baby boomers, CDC augmented the risk-based recommendations to include one-time testing of all baby boomers. Unfortunately, strategies prior to 2020 have had limited success. Only about 40% of all adults living with Hep C infection are aware that they're infected, and new cases among reproductive age adults continue to rise. As a result of this shifting epidemiology, our new recommendations were released and include and now call for screening all adults at least once, screening all pregnant persons during every pregnancy, and the recommendation for testing everyone with risk factors remains in effect, including continued periodic testing for risk for patients as long as risk persists. We are also in the process of developing hepatitis C testing recommendations for perinatally exposed infants. One of CDC's priorities is to support health departments to conduct core viral hepatitis surveillance and prevention. In August of 2020, CDC announced our new integrated viral hepatitis cooperative agreement, which is scheduled to begin in May of this year. The funding opportunity will support approximately 58 state and local health departments to conduct enhanced viral hepatitis surveillance, as well as the development and maintenance of local health partnerships for viral hepatitis elimination planning and implementation. This is a big deal, especially in the surveillance aspect, as currently only 14 jurisdictions receive federal funding. So this is a large expansion, and it represents the opportunity not only to more accurately quantify burden of disease, but monitor elimination trends. Budget discussions are currently underway, and final awards for this agreement are expected to be released in April for a May 1st start date. In July, CDC and ASTO will host a virtual National Viral Hepatitis Program meeting. CDC is also supporting health departments by developing and disseminating tools, as well as offering technical assistance. Some of the tools under development include an elimination planning template, updated comprehensive surveillance guidance, and also guidance for using surveillance data to develop hepatitis C viral clearance cascades. Integrated prevention and surveillance technical assistance will be provided both by CDC as well as by our funded partner, NASTAD. Returning to the epidemiology presented earlier, CDC recognizes that achieving national viral hepatitis elimination goals will require tackling substance use disorder and Hep C together. Despite the clear intersection of these diseases, services are often siloed, resulting in missed opportunities to prevent, detect, and treat hepatitis C and other bloodborne infections among people who inject drugs. Several recent CDC initiatives have focused on increasing these services among PWID and in settings serving PWID. In 2019, the Division of Viral Hepatitis provided supplemental funding to 9 jurisdictions to increase hepatitis B and C diagnosis and linkage to care among people who inject drugs in high-impact settings, which included syringe service programs, substance use disorder treatment facilities, correctional facilities, STI clinics, and emergency departments. Furthermore, CDC supports the implementation of high-quality syringe service programs. This is being achieved through a combination of mechanisms, including developing evidence-based materials highlighting the essential role that syringe service programs play in reducing acquisition and transmission of HIV and hepatitis C among people who inject drugs. Additionally, in 2019, CDC launched a 3-year cooperative agreement to provide harm reduction technical assistance. This funding aims to prevent infectious diseases related to injection drug use and to improve health outcomes through technical assistance in the 4 categories listed on this slide. Recently, CDC announced component 3 of the new cooperative agreement that will begin in May. We'll be awarding about 10 health departments with funding to improve access to comprehensive prevention, diagnostics, and treatment service in settings serving people who inject drugs. We're calling this a PWID service bundle. We're very excited about this component and help to build upon it in the future. Several modeling studies are also taking place, including topics such as updating national estimates of people who inject drugs, assessing the feasibility of elimination of hepatitis C among people who inject drugs, and also assessing the feasibility of eliminating hepatitis C in other disproportionately impacted settings, including correctional settings. As far as work with disproportionately impacted populations, we are also conducting work with the Alaska Native Tribal Health Consortium across the hepatidities to fully eliminate hepatitis in this population. And just before I close, I want to mention an exciting upcoming convening. CDC and APHL are partnering to plan a virtual meeting in the fall of 2021 with key stakeholders to identify high priority diagnostic tools to advance Hep C elimination in the US over the next 5 years. In closing, I know that this audience recognizes that hepatitis C represents a tremendous public health threat in the US, and increasingly so among reproductive age adults and people who inject drugs. However, I also know that we recognize this as a tremendous opportunity. We have a national elimination strategy. We have expanded screening recommendations, short course, highly effective curative treatments, and effective tools to prevent infection. This is a winnable battle, but it will require us working together to increase awareness and accelerate implementation of innovative strategies to identify and cure people living with hepatitis C. Thank you very much for your time, your attention, and your partnership.